So very warm good evening to one and all joining us today for the webinar series on digital transformation in healthcare. We are moving to day 4, discussing telecardiology, modern medical approach, and exploring and implementing Tele ICU in hospitals by two eminent speakers joining us today from Aster Ramesh Hospital, Dr. Dharnidhara Muturu and Dr. Ramesh Babu sir. Thank you, doctors, for joining us today. Over to Dr. Dharnidhara sir to introduce Ramesh Babu sir.
So a very good evening, pleasant good evening to all the folks attending the meeting. Actually, everyone must have heard about Dr. Ramesh Babu sir and what you have read of the internet and everywhere. I will just tell you what we as youngsters know about him. Maybe it was the year 1988 or 89. See, there was a heart attack means in Vijayawada, Guntur, or anywhere in the coastal areas. We either used to take the patient to Hyderabad, NIMS Hyderabad, and NIMS Hyderabad was not easy to get. I mean, although Hyderabad is just 250 kilometers away physically, at that time the road was a single way. Okay, so single way and the hours and hours of roadblock. I mean, I used to remember someone saying that it took 10 hours from Vijayawada to Hyderabad just because someone had some accident happened on the highway. So this fact was important because the entire coastal belt for its cardiology services was dependent on Hyderabad. And meanwhile, you know the sensitivity of time in cardiology, and we used to lose many lives in the transit only. At that time, by God's grace, I don't know how many hundreds and thousands of people started benefiting with Sir's service. Sir came to Vijayawada. He had the opportunity to go to anywhere in the world. I mean, Sir did from AIIMS, Delhi, and he had opportunity connections all over the world. And somehow, maybe it was a divine calling. Sir came to Vijayawada, and at that time, people started, okay, we can go to Sir, we can go to, like that. The overall generations of people got benefited because of the services provided. It all started with in a very humble manner, and he started using technology at a very early stage. All this desire to use technology to give the best to people stems from one common cause of making a human life better, decreasing their morbidity, decreasing their suffering, decreasing their mortality. And the tele services, the technology, Sir started using it in before the 2K, before the 2000 only, before the turn of the century, Sir started using technology. All the fame of 96, 95. Sir, I think one of the few hospitals in India, they had pagers, and they used to alert code blues in pagers. And thereon, Sir started using early mobile phone devices and fax machines. They used to fax the ECGs from peripheries in late 90s at the turn of the century. And from there on, the story has started. And when I first met Sir asked me, Dani, what do you know about Tele ICU? I thought Sir will ask about some clinical topic, something. So Sir is like, okay, you will know clinical topic. You have worked for these many days. But what do you know about Tele ICU? How to make care better, quality of care better? And at some topics, Sir has read well before we have read. We are reading because we want to sit in the exam. Sir is reading because Sir wants to give better service to the patient and reduce their morbidity, mortality. And this is a introduction that I wanted to give, because you can find many things about Sir everywhere and anywhere in the net. But this is my personal experience with Sir, and a privilege to work with Sir. So we will start.
Yeah, thank you for the kind introduction, Dharani. At the outset, I would like to express my sincere gratitude for being invited for this evening session, late evening session. So, of course, there have been a lot of webinars in this COVID era. I do not know how much of interest this will create, but it is really a passionate subject now in this era for many physicians, and it is mandatory, not only passionate. One has to adapt to telehealth to be in active medical profession. So we'll start with the, can you go to the first slide? Yeah, so in fact, we started practice around 34 years ago in my hometown here. And that was the time, as Dharani has introduced, there was no ventilator and there was no cath lab. And in fact, I was losing many patients just because we didn't have a primary PCI facility at the time. We were just giving urokinase. At the time, tenecteplase was also not available, streptokinase or urokinase. And slowly we thought that I'm not able to practice, the way we wanted, the way we were trained. And slowly the people have supported. And that is how we could slowly, in the past 34 years, we could establish stepwise different modalities of cardiology practice in this place. Yeah, next slide. Yeah. Okay. So I'll try to just cover this topic with the interesting evolution of telemedicine across the globe, how it is taken up in India, and also in the past 2 decades, what we could adopt the telemedicine and try to provide the services here. As we all know, the applications of telemedicine or telehealth for that matter predominantly started with the tele-ECG and emergency cardiac care. Though the psychiatry is another branch where it has taken, quite a big chunk of telehealth services. But cardiology, because of the time, the importance of time, and acute cardiac care, the role of telemedicine or telecardiology practices, I'm sure have saved several thousands of lives across the globe, especially in the countries or in the places where it is taken up in the appropriate time. And apart from the acute cardiac care, the chronic cardiac care, apart from the acute chest pain or acute coronary syndrome management, where the pre-hospital management will definitely give better results, outcomes, and improve the morbidity. In the chronic segment, chronic cardiovascular disease segment, it is the chronic heart failure, which is a huge segment of cardiovascular diseases and taking a lot of resources and economic, then the loss of daily lives and all. And apart from these, the applications in preventive cardiology, which everyone has been practicing, we also have been doing it, where we give more or less free teleconsultations to almost about 150 patients every day, especially for better control of the major risk factors, hypertension, diabetes, and hyperlipidemia to prevent. And then just a brief, we'll be discussing about the tools, devices, and the networking, what are available, what is the future, and then what we have been doing in our 2 decades. We started almost in 1998 with the pager, wireless pager system. And as per any medical field, there are any new innovation, there are definitely limitations with regard to the acceptability, the quality, then the cost, and more important, the security of the patient's information, and last but not the least, the medical legal aspects. And then I'll try to just give a brief account of the advances and future innovations. Healthcare, when we were students, more or less, we were thinking we are doing a great service. And of course, we were doing some charity service to some patients also. But with the advances in technology, especially the imaging and the laboratory, now we know that 80% of the diseases can be diagnosed without touching the patient. Through labs and imaging, we are able to, make the diagnosis. And there is a huge change in the concept of healthcare, where technically a more physical appointment oriented and manual examination oriented and manual prescriptions. From this, we have moved over to virtual healthcare, utilizing the technology, the intelligent machines and decision support systems which are available. And now the scope of errors, trying to minimize almost zero error machines. So healthcare is no more considered as a service or as a profession, but it is part of the industrial revolution. Every 100 years, there has been industrial revolution, coal, electricity, and the IT. And now it is the artificial intelligence, deep learning, and the robots and whatnot, everything to give not only in other industries where there is a cohesive forces coming together with networking and more cost effectiveness. That is the key, and serving the masses rather than a few affluent people now trying to provide services. Healthcare is now being designed across the globe in several countries, like several schemes, the popularly called 108 and Arogyasri Ayushman Bharat schemes in India. So likewise, now healthcare is definitely a sort of an industry. Now it is the revolution, it is a part of the Industrial Revolution 4.0. And there are several aspects: the cloud-based health information, telemedicine, then the rehabilitation part, apart from monitoring a lot of physiological and pathological signals, etc. And, we're talking about a lot of Internet of Things, and it's going to be a huge, business. And the technology, the material, siliconized, and a lot of, despite the limitations, there is a huge interest, and it's going to change the face of medical profession. Especially, we are looking at something which is very useful in ICCUs to make quiet ICCUs and less of nursing staff, less of infections. So with all these Internet of medical things, either on premises or in the cloud. And for people who use technology, probably what is a fog layer, the node which is at the edge of a network, to have more speed, more security of the data and all. Though it is there, telemedicine, the utility and the advantages are known for almost over a decade. It is only after this 100 nanometer virus, which has created a havoc, the medical professionals and the patients. So adaptation or adoption of this technology, telemedicine, in the past 2 years, has been, almost every medical student or every physician now knows what is telemedicine, and they are keen to practice and participate. And for this, we have to have something like, which we are not trained in our medical schools, the literacy with the advancing technology. We should try to understand, apart from the functional skills and the effective communication, the safety is the HIPAA compliance and all. The safety is so important in the field of while practicing telemedicine. And the management of the patient is slightly different from just monitoring, because data that is accumulated, how a separate clinical flows compared to a physical patient evaluation and the whole type of systems. This is especially visible in heart failure management after discharge, post-discharge patients likewise. And we know the telemedicine, the reasons why we need telemedicine, we know the shortage, the distribution of expertise and cost savings. And we have the data to say that almost 70% of the doctor's visits and 40% of the emergency room visits could be avoided through telemedicine. Before going to the journey, which we have started in 1998 in Tele-cardiology, I'll just try to see the data that is available even before the COVID from whole system demonstrator study and also the North Yorkshire County Council studies, significant reduction in admission rates and the elective admissions, then average length of stay and the costs involved in the management, and which is very, very important as far as the patient and the confidence levels of the patients. Despite that, it has not taken off, before the COVID, as we mentioned. And we know in India, particularly, it is very, very relevant, and telemedicine hospitals like Apollo hospitals and Ramachandra, these people have started quite early, the people who have been into this telemedicine. And we know the urban-rural divide. And if you see, it is astonishing that in government sector especially, almost they have to see 10 to 20,000 patients, one doctor in government sector, especially in the rural areas, PHCs, and then the community medical centers. So the demand is huge, and applicability definitely, if properly understood, can improve the life health of the Indian the population. This is how it has taken up after this COVID, and even in India now, many doctors and the patients accept this mode of healthcare delivery. And that was visible in our, OPD patients also in 2020, we could see 47,000 odd patients. And newer things have also come up after this, and integrating medical students' course into the Tele ICU and during this period. Now, what are the applications of telecardiology? So as we just discussed, the most important, the major share of saving morbidity, improving morbidity and mortality, the acute chest pain patient, STEMI protocols, the pre-hospital thrombolysis, pre-hospital emergency medical service, EMS, and then interacting with the doctor. So this, in fact, we started almost more than 20 years ago, and definitely it has improved, and the door to balloon time or door to needle time or injection time and appropriate diagnosis is very, very important. Another most important part is acute chest pain with a non-diagnostic ECG. Now, that is one area where, a lot of misdiagnosis and a lot of litigations happen at the misdiagnosis of chest pain. If it is a straightforward STEMI, it is okay. Many people are able to diagnose, but in non-diagnostic, there are several reasons why ECG is non-diagnostic, and 40% of the ECG is non-diagnostic in acute chest pain in the first hour. So in the periphery, it is extremely difficult for the people, and this is one area. Now you know that the troponins, which have come as point of care tests, largely help us in non-diagnostic chest pain. And similarly, the chronic chest pain, of course, rather than telemedicine and the other investigations, now we have chronic chest pain, we have CT coronary angiogram as the gold standard to make a diagnosis. Apart from that, it's very useful, and it's still, of course, evolving, not available. And the recognition and treatment, management of arrhythmia, acute heart failure, and then the modern management of chronic heart failure. This is will be showing the results and how it has impacted the life of the heart failure patients in terms of economy, quality of life, everything. And another important aspect, we have been into STEMI and acute chest pain and pre-hospital for 20 years. But now, in the past 1 year, we have been focusing on hospital telemonitoring, emergency room triaging, and then even we started the cath lab monitoring and every ECG or every patient, and even in non-critical wards, in-hospital cardiac arrest is an important topic where the care can really improve, appropriate identification, timely management can improve the outcomes significantly. That is what the literature says. And we have also seen, we'll be showing some of the patients. Dharani is very enthusiastic, monitors all the data every day. And then definitely we have contributed from the central command station, which we will be showing. We can monitor all our patients across the cluster, almost 700 patients we can monitor every patient sitting here in the central command station. Then another topic which we started is post-discharge, the 329 program, wherein after discharge in the initial 30 days, there is sudden cardiac death happens in acute MI patients who apparently look normal. This is one area where by appropriate attention, you can reduce the reinfarction and the sudden cardiac death. That is another important area which is neglected, and I think there is some definite scope. Apart from the tele-rehabilitation and then optimal control of the risk factors, hypertension, diabetes, and all. Another important aspect which is showing the data, the alarm fatigue with the quiet ICU concept, definitely the Internet of Things, and then we can definitely reduce the human involvement and patient disturbance, and then sometimes loud ICUs can increase the morbidity and even mortality, as some data is shown. So, as you know, there is the burden of ischemic heart disease. It is the commonest. Atherosclerotic cardiovascular disease is the commonest cause of mortality. Almost about a third of patients succumb because of the ischemic heart disease. And most importantly, the golden hour concept, as all of you know, almost for the past decade or decade and a half, we have been ardent supporters of this, try to educate a lot of the doctors and people in and around this. And then you know that every minute is very, very important. And sometimes it's very unfortunate when we see a patient in an emergency room with acute chest pain, they still delay the, taking a decision. And we have lost patients even when they have reached the ER because 5, 10, 20 minutes is lost because in decision making, though when we are ready. So time is very important. You may not be able to save unless you open a very, very important critical vessel like LAD, proximal LAD, and this. And then the other important, the segment of patients is heart failure, as I mentioned. The overall prevalence is increasing, and with the direct and indirect costs, and with the recent, wearable sensors, the electronic devices monitoring, and then proper hybrid management, rehabilitation of these heart failure patients, both visits and also the online and the remote monitoring, we can improve the quality. This is also very much shown in the studies, and it looks very important part. So this is the definition. All of providing service for the people at the distance, and we know in India 70% are into the. So this is the second set, Another important part, in fact, we had 2 patients who collapsed while waiting in the OPD, outpatient department. They had mild discomfort, but they are afraid of going to emergency room. They think it is gastric trouble. And then we had to, immediately, the patients were having VF, we had to defibrillate in the, in the OPD itself, and then shift to the cath labs. So this is another area. So delay can happen even in the hospital. So the pre-hospital management, immediate attention, which is very much feasible even for a patient sitting at home. Now you have this, even the ECGs available, with the pocket ECGs available, and all the knowledge and the technology we have to utilize so that the patient reaches in time, properly transported. And Another important thing, the people who have heart attacks at the weekend and night are 5% more likely to die because of delays in treatment. And this is another very important aspect close to my heart. And our team is also now very much conscious about it. The in-hospital cardiac arrest in emergency room, so proper emergency room triaging, and then outpatient, the OTs, then the intensive care units. And the other important is non-critical areas, the wards where we feel patient relatively look apparently normal, and death in the non-critical area should be avoided. Appropriate education and preparation, readiness we can prevent. And so this is very much proven, and significant variability in hospital cardiac arrest survival exists across the hospitals. And this is despite, so that means the teams which are ready and then to take up and then predict, most of the times in hospital cardiac arrest, prior to 4 hours before the arrest, there is some variance in the vital, parameters, and if you monitor them carefully, so we can monitor any of our patients from any of the rooms with the central monitor. And even in ICCUs, the nurses get fatigued and they can't fix their case on the monitors. So even ICU patients, we have a central monitor system, and that definitely has helped us. And people become more alert when they know that ICUs and all you're having a second eye, then they are more alert and they pick up, arrhythmias and all almost at the same time we pick up, though sometimes there is a time lag. So these are all the investigations, and these are all the devices which are developed over a century. And this is our central command station, in which we monitor the patients from different areas, critical patients, and sometimes even non-critical rooms. Sometimes patients want to be discharged into the rooms. They don't want to stay in the ICU. We are, doubtful whether something may happen, and then we connect these patients also into this. And then this is the applications, the common applications which others also use. These are the things which we use, the Visual Basic, Oracle. And the electronic medical records with us are in place for over 5 years now. And then these are all the technology and softwares which we use. So these are the digital technologies useful in different areas, the pharmacy, in hospital, the laboratory, outpatient education and research. And then these are all the several physiological biosignals. And then still, some are in the phase of evolution, need to be proven, but some are already proven. And the future is definitely going to be, more advances in these things. I will not go into the details of all these sensors and what are the various advantages, disadvantages. This is another important area where alarms in the ICU gives a sense of insecurity to the attendant visits. 10-12 alarms simultaneously we used to have earlier, with all sounds and all. Now we know that almost when the alarm noise is more than 50-55 decibels, it can cause harm to the patient, and almost 862 patients died between 2005 to 2012. Estimate. This is an estimate. These are alarm-related deaths. This is in the St. John Hopkins. So in India, the delay in time and is there. Now, just after the introduction of this technology and all these things, I'll just try to present for the next 5 minutes for relief, how the evolution of communication has happened over centuries. And it's quite interesting how humans have evolved, from the chimpanzee, how the tongue communication, the specific centers for language, music, and, so back to basics, some of the language areas for human brain, the angular gyrus, the supramarginal gyrus, and then Broca's area. And it's quite interesting to see this theory that the human vocal apparatus is intrinsically digital on model of a keyboard or digital computer. And this, when and how during the course of human evolution, the transition from analog to digital structure has happened is an area of interest. And the earliest medical messengers, the Belgian pigeons, are supposed to be extremely good. And these were, in fact, taking the, like what we take morning rounds and evening rounds. These pigeons were, they were given food in a particular area where the patient is there. They would go there, and then the patient's vitals, pulse rate, and the temperature, these were mentioned. And Philip Arnold, in almost, 1899, promoted this concept, which looks very, very interesting. And this is, these probably saved, the pigeons have saved a lot of lives. Of course, humans have misused it to do the drug trafficking also through pigeons. So, and from pigeons now, cellular mobile, which gives a lot of information, a lot of communication, comfort to our patients, doctors, colleagues, teams to give better care. So we have evolved from radio news, 1924 to now space medicine, then all these microphones, and the first airport from where the telemedicine was started, Massachusetts. Then hospital, this is the electronic stethoscope where you can have an auscultation. And
Tardant echocardiography. And since the robot arm has human-like kinematics, all typical
cardiogram, and then now what this is another point of care test in case of non-diagnostic ECGs to avoid time delays. So once you have proper pre-hospital diagnosis, then now we started shifting our patients directly from ambulance to the cath lab. This saves almost 15-20 minutes. And it is shown that the door to balloon time, once it improves, even by 15-20 minutes, it improves the morbidity. So the biggest hurdle is convincing the patient during the transit or the attendance and the financial aspects. So otherwise, every patient should be ideally shifted from ambulance to the cath labs. And, these are some of the wearables. This is what the heart failure management, the earlier old type, and then the newer modalities, the modern model of heart failure is evolving. And definitely this is much superior. And this is patient focused. It will cut down the admission rate and also the loss of our quality adjusted life years. And a lot of studies have come up in the past few years with regard to the wearables, and then identification of the atrial fibrillation, and then congestive heart failure, early recognition of fluid overload or impending failure. So to prevent recurrent admissions. So recurrent hospitalizations could be prevented. So what we have done in the non-communicable diseases, we started quite, almost 8-9 years ago daily, and, giving suggestions with regard to hypertension, diabetes, and emergency. We started quite some time back. And then the post-discharge, as I mentioned, the initial 3 to 4 days readmission rate, within the first 30 days in different departments, it is 5 to 10%. And if we can address the problem, be in touch with them, definitely that can, we have shown that in 3 to 9 program, we have shown that it can be reduced. This area is the most interesting for us, Tele ICU, Tele Emergency Room, and in-hospital cardiac arrest, which I will be showing some of the cases. This was the first, telemedicine tool which we used in 1998, where our cardiologists, anesthesiologists, and the drivers, they used to have this. And for any alert, cardiac arrest, code blues. Otherwise, we used to have an intercom, then the person is not available somewhere. So this improved the timing. And, every minute after the cardiac arrest in hospital, every minute delay will worsen the mortality, or, the recovery rate will come down by almost 15% for every minute. So very, very important to address within the first 1 minute in hospital cardiac arrest. So in the next is our, in 2000, year 2000, we donated almost 16 computerized ECG machines to the surrounding doctors who are good, who are doing good practice, but then they were confused about the chest, diagnosing chest pain. So we donated this, and then through the fax, most of them were, forwarding these ECGs to us. We used to give them the advice, and they used to give streptokinase or urokinase at that time. So, and then this is how we did, and more than 1 lakh of patients we did. And also we promoted this concept to the doctors, peripheral doctors, about the value of golden hour. At that time in 1996, we distributed almost 2 lakh pamphlets to these patients. We used to give a lot of IMA talks at the time. And then later we have this device wherein directly through this SIM card based device, and directly we're getting into our mobile phones, the ECG. Now I think it's no more available. Different models are available now. This is how we used to have the ECG, and then transmit directly. We used to give the advice to the patients, and then we introduced an app for the patients for emergency or any the labs or ambulance request and all. And then we started this program also in 2013. We conducted a seminar involving the stalwarts in the field of telemedicine, and tried to create an awareness amongst the public and the professionals, medical professionals here. And we created a hub and spoke model at the time, and from our main center and then the other centers to the mainly the mandals. And these are the areas where we have inaugurated in 2013-14, and several telemedicine centers we have done. We started even two-wheeler ambulances, four-wheeler ambulances at the time.
Okay. So,
yeah, also post.
Sir, Syed Abdul patient, sir, he came for first visit, post CABG.
Yeah, also post-surgical patients follow up instead of asking them to come every time. So we used to have telemedicine centers in the periphery, and from there our surgeon used to give them the advice on the post-operative patients. This is one patient the Belgian patient whom we picked up from airport where we have a telemedicine. This was in 2013. And he was having antival MI. We picked up and then did the radial PCI, and next, within 48 hours, he flew back to his place. So telemedicine definitely has helped a lot of people in these 10, 15 years. And yeah, this is another 3 to 9 program where it is a hybrid, where sometimes our people go and visit, and the other times we use telemedicine to track how they are and giving them advice. And they can call us anytime, 24/7, our central command is available. They can call us anytime, the post-discharge patients, or anybody for that matter, any discharge patient. So our people are there around the clock, and then they'll give the suggestions to them. So we had a lot of advantage because the pilferages were less, leakages were less. The readmission rate came down significantly after this 3 to 9 program, and we received an award for this the 3 to 9 program, FICCI, and then the Asian Hospital Management Awards in 2017. So we conducted a lot of tele-education sessions, and then we also started simultaneously the stroke program in the periphery where CT scans are available. Our neurologist is in touch with them, and then to provide the thrombolytic therapy when it is diagnosed as a non-hemorrhagic stroke, which is indicated. This is our central telecommand station, which we are going to expand further, wherein we can monitor all the patients, all the ER admissions. First, the patient is admitted into ER bed where monitor is available across all 4 hospitals in the neighboring districts, all these patients. And then we can monitor any of our patients. And then our cath labs are also recently connected to this. So something happening, and even this, the imaging in the console room also can be transferred to the cardiologist when it is really important to guide them. So likewise, and then ambulance is another one which is done. And then the other important thing is now we have plans to have a critical care specialist around the clock to monitor these things. We know that the effective CPR is very, very important, and we can monitor to see how they are performing, guide, and while of course giving training, periodic training to all these people. So the efficacy, and now, it's shortly we are going to have probably 5G in India from 29th August, probably after the annual general meeting of Reliance and other people in the next 2 hours. So we are now ready, update, and this is how our central command doctor can communicate with the doctor inside this ambulance. And we have all these things. So similarly, the transport, we can monitor, we can guide the doctor and the nursing staff. And then emergency room is another area. We are trying to hook all our beds to the central command station. Emergency room is one area where these ER physicians are very much stressed out. Suddenly there is a gush of 2-3 patients, and then apparently normal looking, even chest pain patients, ECG normal, suddenly they collapse when the attention is diverted. That is how we connect all the patients till they are stable. So, like
call him.
communication with the central station like this. And this is Dharani, where he will be explaining today and then tomorrow about what are all the telemedicine activities, telecardiology activities, which we have taken up. And so this is another important the session initiation process protocol speakers we have connected. And here, whenever one problem we have noticed is when in the night time, when our sister or the doctor notices, tries to ring up, sometimes they don't pick up. So what we did is we have connected through our telephone to a speaker there. So in all the wards. So wherever the problem is there, it is not a central speaker or central system, but it's specified. This has helped us. And then they immediately inform the doctors, and then they go and see the patient. So the high alert speaker, which we have all the wards. And the time the cardiology has picked up in telemedicine, it is the field, it is this group of patients who have benefited most from telemedicine, as we have discussed. And just few cases in the past 1 month. So 4 cases in the past 4 weeks. Just Dharani has picked up these, and then we made these slides. So this patient, who was shifted after initial stabilization, suddenly had VT, fast VT, and low pressure. So immediately it was cardioverted. And then another patient who was shifted again had similar patient. Mostly the patients don't like to stay in ER or ICU. As soon as they're stabilized, they would like to be shifted to a room. So we connect even to the room also. And there's another important post-operative phase. Sometimes post-operative, because of sedation and the patients do not complain, they can have silent myocardial infarction. There's one patient which we picked up in the past 4 weeks, where the patient had got an ST elevation. Of course, he complained of some chest discomfort, but many times the post-operative patients may not complain. This is one segment where we need to, recently, unfortunately, we lost a patient in one of the units who was shifted from ICU to a room. And, he was not on the monitor. He was feeling absolutely normal. The doctor also felt it's fine, but that is probably a preventable death, because it is sudden. It must have been a VF, must be having a silent heart disease, because it was operated for some other by general surgeon. So these things definitely in hospital cardiac arrest is a field which is being focused now. Information is not sufficient even across the globe. What are the measures? What are the workflows? How you can improve the outcomes in patient cardiac arrest? This is another patient in the emergency room, as I mentioned. So patient came with acute MI, and then the ER physician was looking at another patient because patient was looking stable. Patient suddenly developed bradycardia. If you delay it, sometimes bradycardia dependent ventricular fibrillation patient can have. So immediately attended, given atropine, shifted to the cath lab, and then of course he continued, and then pacemaker. And this is our cath labs. These are connected to hook to this, and these are the initial, more than a lakh of people, students, doctors we have trained in the past decade or so for BLS and ACLS, and then told them the importance of the golden hour. And then one of the students, in fact, could save her father after attending the session by calling us immediately, by telephoning, and then immediately we could send our ambulance. So like this, we conducted a lot of seminars on this, and then national seminar Telemedicine we conducted in 2018. of course, the STEMI program, the golden hour importance, the role of telemedicine in STEMI we have. So yeah, these are, the future ICU, how it is going to be, virtual, augmented reality, virtual reality, another important field. And this is also, similar. And, this is the drones, the role of drones.
112 operator, what is your emergency?
It's my dad.
Be there.
I think he had a heart attack.
Drone is on its way.
I'm outside.
To your father. Good. I can see that the pads are properly applied. Joanna, please stay clear of your father.
Yeah, within 2 minutes. Within 2 minutes, defibrillation can be given, and it's almost sure death is prevented. So, the role of drones, and then Astor has recently started drone. So future ready for takeoff. So a lot of innovations with regard to wearable sensors, IoT, drone technology, and it is going to bring in huge change. Still, the India adoption is a little slow and less, but I'm sure in the coming 2-3 years, definitely better healthcare can be delivered in India by proper application of telemedicine with proper national programs, national health programs, and now that the EMRs and the national database for health, even from birth, is being planned by Niti Aayog, they're taking aggressive steps. I'm very happy to note that all the database and is being created for better healthcare, which is more cost effective, definitely. So hospital at home is the future, yes. And of course, we know any innovation, reimbursement problem, and then the clinical issues, the quality, then some people do not have satisfaction. And then of course, medical legal causes, the quality of the report that they process, analysis, the data transmission, and the social issues. So this is roughly what is happening in cardiology wing with regard to telemedicine and what we could do in this tier 2 city, tier 2 or tier 3, whatever. So we have a lot of dynamic people like Dharani and the youngsters. Some of our people we have contributed, like Dr. Sudarshan, for this telemedicine program. He's in the National Telemedicine Society, and still a lot to be done with regard to telemedicine for creation, and then trying to help the other colleagues of ours by trying to have pilot projects with them to monitor their patients and see whether we can, contribute to the healthcare of their patients also. So I thank once again the organizers, the organizing committee, and the Critical Care Society of India for giving me this wonderful opportunity. I know this very late, and it is a long talk. Thank you once again.
Yeah, thank you, Doctor. Indeed, great presentation. We can take up the questions in the end, and we are moving to the session 2 for today. On exploring and implementing of Tele ICU in hospitals by Dr. Dharanindara Muturu, MD, DM, Consultant Critical Care Medicine from Aster Ramesh Hospital. Thank you, Doctor, for joining us today. Over to you.
Sir, first of all, a very elaborate talk, and thank you so much for that, making my job easier of how we are doing things and all that. So I'm going to keep it, I'm going to just discuss on how we started this Tele ICU. So first thing is, I would like to tell you that first thing, when we wanted to start a Tele ICU, we had the problem with the technology. I mean, where to source the technology. I mean, what technology to use. I mean, all the proprietary, all the proprietary devices that we have gone through were costly. They were very costly. They were very, beyond the cost benefit things that we can give to the patients and all that. So we developed our own indigenous system. We had developed our own indigenous system, and this indigenous system helped us to function better. So basically what we have is we have a central command station which is based in Vijayawada, and the central command station in Vijayawada is connected to Guntur and Ongole, our sister hospitals. So our sister hospitals uh, are there in Guntur town and Ongole town of Andhra Pradesh, and they are along the Vijayawada-Chennai highway. So what happens is that in Vijayawada, we monitor the patients from Guntur and Ongole, the ICUs, the wards, and the high dependency unit areas. So basically, we have data, a lot of data coming in, and we have staffing in the Tele ICU. We have a Tele ICU nurse. We are having a general physician or a post MBBS doctor in the Tele ICU, and we are having a Tele ICU trained nurse. These staff, they monitor the ICU, they monitor the data in the Tele ICU, and they alert the respective ward in where the hemodynamic abnormality is happening. For example, we detected a problem happening in Ongole. For example, in the ward, some patient is having an acute chest pain and hypotension. So when we are able to detect it before they do, sometimes when we are able to monitor those changes in their ECG and vitals, and we alert them, especially during the night hours, during the after 6 p.m., after 8 p.m. So when you can have some lapses in monitoring. So with the use of technology, we are monitoring these hemodynamic data, and we are able to detect them in the Tele ICU and inform them. And after conducting 6 to 7 months of usage trial, we have taken reviews from the respective consultants in Guntur and Ongole also. So what we had a review is that it made their life easier. First thing is everyone knows the management of the case. Everyone is trained in managing a case. The problem comes when you have to detect it in time. So usually the best of the manpower all across the world stays from, for example, 8 a.m. to 6 p.m. or 7 p.m. So after 7 p.m., anywhere in the world, we can see we are having lesser strength in human skills. So to compensate for that, if someone is catching these problems as they happen across the cluster, we are able to give alerts in time. So the other part, what we have done is we have manned this ICU with a telenurse and a
Sorry to
doctor.
interrupt, doctor. Are you changing the slides because we are still in the central command station?
Yeah, 1 minute. I think the slides got stuck. There is some issue. 1 minute.
Sure.
I am changing and you're not able to see. Yeah. Now you can see.
Not yet. You need to share the screen, doctor.
Yeah, 1 minute. There is some issue with the sharing component. Just 1 minute. I'm sorry for that. There is some issue. We're going to sort it out. Yes. Yeah. Now you can see my screen.
Yeah, screen is visible. Presentation yet to. Yes.
Yeah. So now, yeah. So you can see it now, right?
Yes, you can make it full screen. Yeah.
Yeah, the full screen, there's some issue with the full screen, so I'm going to play it like this.
Okay, sure. No problem. Yeah.
Yeah. So in the Tele ICU, as I described before, we have a Tele ICU nurse. Okay. And this nurse alerts the respective ward after seeing any changes in the hemodynamics in the respective ward. After initially after starting the trial and after 2 months into the trial, we felt that sometimes people are not answering the telephone in the respective ward. Maybe they are engaged in some other work, they are engaged in some injection duties, they are engaged in some monitoring duties, they are not near the phone, so they were not picking up the phone. So what we have done is we have placed a speaker system. The speaker system, what it does basically is person in the Tele ICU monitoring these patients can alert the personnel in that particular ward of any hemodynamic abnormality. So the speaker has made the life very easy, and it was an idea that Dr. PRV got in one of the morning meetings. One of the doctors were complaining that sisters don't answer the phone and all this and this, and then I think Dr. PRV got the idea, and we put speakers across the cluster. So what I want to tell you is, whatever system you have started, it will only improve when you monitor it daily, when you're thinking about it, how to improve the system you have built daily. And that is happening across the cluster thanks to Dr. PRB's everyday morning meetings. So the other thing that we have noticed is the hemodynamic abnormalities, as sir have told, exist before the rapid response team call or code blue. So before the actual code blue happens, the hemodynamic abnormalities can be detected for half an hour to 1 hour. So after a cardiac arrest happens, it takes a lot of human effort, manpower, and resources to get and return of spontaneous circulation. But if we are able to diagnose the cardiac arrest before it happens, the amount of resources that you put in, the amount of effort that you put in saving the patient is far lesser. So that is the key of monitoring patients in Tele ICU. So these are some of the abnormalities that we have picked up, across various units. You can see, for example, there is a ventilator disconnection in this situation, and the patient started to have hypoxemia. So once the hypoxemia reaches below 50, at the time you'll have a cardiac arrest. And once a cardiac arrest, to get an ROSC with a neurologically intact patient is equally tough. So in these situations, ventilator disconnection was detected and hypoxia was detected, and immediately that bedside sister was, helped. For example, in this situation, it was 6:58 a.m. in the morning. So 6:57 is a very, very important timing, because at the time the shift of nursing happens, the handover nursing duties, and usually people take a morning break at that time, and that is the one time that lapses can happen. So for example, you can see the next slide. The patient is having a bradyarrhythmia. Although his other vitals are looking fine, there's an art line in C2, the saturation is looking good, and this patient is having bradycardia. You need to troubleshoot so that it doesn't deteriorate further. And you see this, as Dr. PRB sir has discussed before, the electrical problems of the heart, especially the rhythm disorders, are fatal within seconds. Rhythm disorders are fatal within seconds. You see, we have picked up a ventricular tachyarrhythmia, and we have immediately cardio-voted in this slide, in this particular slide. So all these time-sensitive interventions, can be very important to patient outcome. For us, it is one of the patients. For a family member, it is their entire hope and spirit, that particular person. So ability to save a human life using small technological advances and applying them is very, corner on very central pillar of the Tele ICU. Here you can see we are doing monitoring of a, ACLS code in the ER. So you can see that the patient had a ventricular fibrillation and he had a cardiac arrest. They have given him shock and they're continuing CPR. You can monitor the quality of the CPR. You can monitor the depth of the chest compressions, the rate of the chest compressions, whether every 2 minutes a compressor is being changed or not. If you are off-site and you are distant away from your ER or ICU, you can still monitor what is happening. You can do a e-monitoring of the cardiopulmonary resuscitation using the Tele ICU, Tele ER. And anywhere in India, what we have found out is transportation of a critically ill patient has always been an Achilles tendon. Whether it was the days back in 1980s when road networks were not very good, or even for that matter now, Transportation is always an Achilles tendon then and Achilles tendon now also. So what we have done is we have made these 5G ambulances using indigenous technology. The audio video camera that you're seeing are sourced from manufacturers, and we have placed them in the ambulances monitoring the patient bay area. So we have triple parameter monitor in the ambulance, and we have a audio visual camera uh, which can monitor the whatever is happening in the patient bay of the ambulance. We can also instruct the accompanying doctor how to improve the patient's hemodynamics, how to resuscitate the patient better, what are the things to watch out. It is very important for a patient who is getting transported on a ventilator, especially the tele-ambulance. What happens is a lot of times when patient is placed on ventilation and is on transport, there may be tube disconnections, there may be tube kinkage, the patient might not receive effective tidal volume, effective ventilation, and there may be hemodynamic disturbances that are not noticed by the accompanying persons because of their lack of experience. So everything can be mitigated. The entire process, the Achilles tendon of transportation of critically ill patients in India, the solution is the 5G, the ambulance that the PRB sir has designed and thought of. So all the hardware and software that we are using are indigenous, made by us itself, using the help of our engineers and help of our ideas from Dr. PRB. So what we have noticed is all over the world and with us also as well, we have noticed a reduction in morbidity and mortality. So we have data coming up, almost from a decade ago from North America, that the mortality, length of stay, and composite outcomes have reduced. And what we have seen is matching to what the earlier trials were telling. The earlier trials, whatever they were standing to, and what we are observing is on par. So it is also giving us more confidence to transport a critically ill patient.
Doctor, please unmute.
Time, right?
Yeah, now you're audible. Yes.
Yeah, so I was audible. I was not audible since when, ma'am?
Just a few seconds.
Okay, fine. Yeah. So here we can see this tele-ambulance, 5G ambulance. We have a smart console where the doctor in the hospital can interact with the patient bedside physician, whoever the paramedic or the physician who is accompanying the patient. This is the console where he can interact with the expert in the hospital. So the expert can discuss the problems of the patient and assist in resuscitation on transit. So resuscitation should happen in transit, or else the patient will not be able to reach the hospital itself. So that is the key point that we have noticed. And tomorrow we're going to discuss more about the tele-ambulance, and we're going to talk about how we designed it and how we developed it using indigenous software. So I will conclude today, and thank you for the opportunity. And I'll thank our Managing Director, Dr. Ramesh Babu, for his time and presence. And I thank Mr. Soumya for organizing everything.
Thank you, Doctor. We have a couple of questions. So I will ask one by one so that you may answer accordingly, even Dr. Ramesh sir also. The first question is, could you explain us on how we can equip or train our cardiologist?
Dr. Ramesh sir, you answer this question, sir.
Yeah, cardiologists are very busy. So, but most of them now use WhatsApp messages, and then the cardiologists utilize to sign the discharge summary. We send the discharge summary to their mobiles, and Now our plan is the junior cardiologists or non-invasive cardiologists are utilized to monitor these, and they pass on the transmit the message. So nothing great technology for utilization. Only issue is the most important aspects are the medical legal and then the how to maintain the confidentiality, these things. Otherwise, cardiologists, I think most cardiologists are using now the telecardiology, based on the need and then their place of work.
Thank you, doctor. The next question is tele-cardiology is reducing unnecessary hospital admissions of patients? And if yes, how well we can improvise the treatment process?
Yeah, sure. Almost several, thousands of ECGs and several hundreds of patients we have seen, and it acts in two ways. One, some patients have anxiety or the nature of the symptoms and all, and the transport all over the globe, and even in our cases, we have seen we could avoid, we could reassure, because some of the patients are anxious and then any chest pain. The richer patients travel and occupy the beds in the ER, and the poorer and the middle sections wait for a day or two. The other way is also right. The cardiologists, like, cardiac chest pain with normal ECG or non-diagnostic ECG. This is one thing wherein, one political MLA, we could diagnose by the simple chest discomfort nature, and though ECG was non-diagnosed, by the time he came here, it was more, and then he had critical double vessel disease. So the non-diagnostic ECG is one area where we thought will be very useful for the cardiologist intervention, because we know with experience. And then point of care test. Now the troponin is going to help quite a bit. So point of care troponin and other features. Majority of the times, acute chest pain, we can make a diagnosis. Apart from the many cardiologists are now giving for preventive cardiology, handling and then heart failure patients, chronic heart failure, hypertension, diabetes and all. So it is definitely a boon for cardiologists, because many times cardiologists can sit at home and then answer their patient who are admitted. Sometimes very anxious patient wants the cardiologist to see them in the midnight, which is a non-cardiac pain. And even if the junior physicians tells they won't agree, but instead of moving out. So cardiologist life also has become quite comfortable with this telemetry.
Thank you, doctor. The next question is, fantastic services rendered by telemedicine approach, but for urban areas, what are the facilities for rural population?
Yeah, most of our services are for rural population. In fact, if you see from year 2000, where we have donated 16 computerized ECGs for the rural population, actually the mandals in Krishna, other neighboring districts we have given. And all the now telemedicine, now we have donated telemedicine centers to some of the government community hospitals, community health centers. And from there, we keep answering and we keep communicating with the doctors. And it is much more useful for the rural population, because in urban, they have a lot of other doctors. And then, they have the facility opportunity, but for only, it's definitely useful in India. And we have been doing it predominantly for the rural sector.
Yes, thank you, doctor. The next question is to Dharnidhara sir. How does a virtual ICU work, and how it benefited you?
Sir, first thing I want to get across is virtual ICU and tele ICU are not the same. So first thing is tele ICU, the patients you're monitoring are actually there within your campus, or there in one of the sites that you are monitoring. Okay, so what is happening is you are having a second eye, or for that matter a third eye, on the patient's hemodynamics and on the patient's clinical condition. And there is some bedside doctor already, there is some bedside nurse already. But what I want to tell you is, however, how many ever the doctors that we are producing, whatever is the doctor to patient ratio we are having, doctor to patient to nurse ratio we are having, it is still not satisfactory or on par. So the Tele ICU, what it basically does is, when you're not having 1:1 ratios, or you're having 1:2, 1:3 nursing ratios, it will help in better patient monitoring, giving better patient care. And there is always a fatigue component in the night duties. Uh, there is always a chance that the human mind, human brain, human potential is not the best during the night time, or during the evening time, or during the off hours. So what the Tele ICU does is, it acts an additional shield, an additional layer of security for giving quality to the patient. So that's the Tele ICU. And Tele ICU, what we found out, what advantages that we had were, we were, I am in the ICU in the morning hours, and even I'm focusing on one bed. For example, on bed number 1, there is a very bad patient. He requires intubation, central line, art line, and he requires renal replacement therapy. I'm focusing on this patient. There is something called fixation bias. There is something called fixation bias. My attention is fixed on one bed because he requires all that, and suddenly a post angioplasty patient in bed number 10 is sick. He had developed a ventricular fibrillation, he developed a ventricular tachycardia, and what happens? I get an alert, that patient bed number 9 is not doing well. Bed number 9 is not in my sight, he's behind. I'm not able to see him directly. My attention is on bed 1. And when my attention is on bed 1, and many of the nursing staff's attention is on bed 1, you can see that bed number 10 patient is deteriorating. So it will help you a lot when you're having a busy ICU. When you're having a busy ICU, it will help you. So at the end of the day, in this fourth healthcare revolution, as Dr. Ramesh has put it, is going to be using technology for benefit of the patient. So that is how it has helped us.
Thank you, doctor. The next question is, how do you deal with patients who have cardiac stunts? Placing of stunts can say the patient is completely recovered, and are they prone to cardiac arrest, strokes in the later stages? How telecardiology is applicable for such patients even?
Yeah. So the stent implantation, earlier they used to be acute stent thrombosis before the advent of these dual antiplatelets and good P2Y12 inhibitors. And then within 48 hours or within first 30 days. Likewise, like any acute myocardial infarction, the mortality is almost 15% for patients who are discharged after acute MI or acute coronary event, even when the stents are put and all. So the earlier data. Now with the stents now, the thrombosis has come down significantly, so less than 1. But still there are many ifs and buts post-stent deployment. Some patients do deteriorate because of microvascular underperfusion and then the microvascular obstruction. There are many things which we do not know. Otherwise, the important first 48 hours is very, very critical. And most of the times we observe the patients, especially when a large infarct is there or moderate LV dysfunction. For straightforward, we discharge almost within 24 hours. But for any patient, not only stent and any post-bypass patients and post-ACS patients, post-heart failure patients, post-acute heart failure, first 30 days is very, very important. So we keep doing 3 to 9 program. As I mentioned, we have a hybrid type of management, like on day 3 our person visits, day 7, day 12, we interact with video consultation. Whenever there is a doubt, we again go and visit the patient. So first 42 days we have been watching this. We closely monitor these discharge patients, and definitely we have found and prevented certain major issues happening.
Thank you, doctor. Can we take up one more question?
Sure.
Yeah.
Yeah,
So
please go ahead.
yes, very interesting question it is. It is about, sir, could you explain in detail about Tele ICU Safety?
Yeah. So Tele ICU Safety. Okay. So first thing that I want to explain here is any technology has a potential to fail. Any technology has a potential to fail. For example, the Tele ICU also is connected by the internet. It is requires power, uninterrupted power. It requires uninterrupted internet connection. It requires continuous monitoring from a trained individual. So failure can happen at the network side, from the power side, from the personnel side. So these are the 3 points where failure can happen. But what I want to tell here is we are not relying solely on the Tele ICU for patient care. There is already a bedside physician. There's already a bedside sister. So we are a second eye. So Tele ICU is for monitoring patients and giving services when there is a qualified bedside physician and qualified bedside nurse. We are not replacing them. We are giving them a web of protection. We are giving, just like a sniper provides cover for advancing infantry, the Tele ICU is like that. It is like a sniper keeping an eye for an advancing infantry. So it is a second web of protection.
Yeah, Dharani, yeah, it's not only that. The safety of Tele ICU, of course, apart from the technical reasons and the networking failures and all, keeping that aside, when you are trying to provide it to a general surgeon who has operated his patient, who is in the periphery, in the rural area, and he wants his patient to be monitored overnight, 24 hours. So definitely the Tele ICU is useful for such people because they live on a nurse or a compounder who doesn't know when to disturb the doctor and all. So it's going to be hugely effective. Safety in the sense, one is the transmission, data transmission, which we have been seeing for the past 7-8 months. Data transmission of this has been very effective quality-wise, the identification of the rhythm abnormality-wise. And in hospital, as I mentioned, there is data to say that about 4 hours prior, there is a gradual worsening or observable changes in the parameters before in-hospital cardiac arrest happens. So safety at several levels. And then pre-hospital, Tele ICU you are mentioning, we have some telemedicine centers which are manned by junior doctors where acute MI in front of us, patient had ventricular fibrillation, and we keep all defibrillators in those centers. And that junior doctor could save that patient by, we could identify, we guided him. So safety is enormous if properly applied. Of course, there's a lot to be done in India, but whatever units you take up, if you try, and it is very, very safe in a sense that another thing we were discussing, Dharani and all, in fact, our sisters, doctors have become very alert, and compared to the earlier phase, now by the time we announce, they're already bedside, the ventricular tachycardia, bradycardia. That means they're more vigilant. So when somebody is being observed, that is another important thing, safety in a sense that, definitely it is safe for the patients.
I agree with Dr. Ramesh sir very much because nowadays they're like competing with the Tele ICU.
Yes.
Sir, they didn't tell us, sir. We only noticed it first.
Yeah, that's very good to hear.
Thing is, there are many indirect ways that things work. We'll think, everything is not 1 + 1 = 2. There are many indirect ways that things enhance with the Tele ICU. You'll only know it when you are actually doing it.
Yes. Thank you, doctors. So I think we can wind up the session for today. So on behalf of MedPiper Technologies, IRIA Kerala, Hospex, Indian Junior Doctors Association, JournoMed, ISA Thrissur City branch, IMA Thrissur City branch, and Insta Clinic, we would like to thank Dr. Ramesh Babu sir and Dr. Dharanidhara Mutru sir, also, who have joined today in detailing the journey of telecardiology. Very fascinating, doctor. I personally like the pigeon story that you have told. And the second discussion on exploring and implementing of Tele ICU in hospital. Even though ICU is known as a pressure point, it's very good to see that your hospital is handling it very nicely. Thank you, doctor, for explaining everything. See you for the next webinar, that is tomorrow.